Good afternoon, everyone, and welcome to the last of the QIAGEN-sponsored seminars to the European Society of Mycobacteriology. As it's a pleasure to see all of you this afternoon. I really like to invite you to follow what is the program of the European Society of Mycobacteriology. As you know, we are planning to have the next meeting at the end of June, probably in Bologna. It will be a face-to-face meeting, but will also allow the hybrid connection. As a housekeeping note for today's webinar, you know that you can send us your question during the talk using the live chat window. You'll need to sign in to YouTube to be able to do that, either a YouTube or a Google account, and join the channel. The live chat messages are not private, so everyone can read them. Include your affiliation in your question, and in case we won't have time to answer to your question, if you include your email address, I'm sure that today's speakers will be willing to reach out to you with the answer. I would ask you to wait until the end of the talk for the discussion. I think it will be very nice to have a joint discussion after the second talk. But anyway, the sooner you start writing your question in the chat, the more likely the speaker will have time to answer to it. If you are not able to ask your question via the live chat, you can email them to the office at esmmicrobacteriology.eu. As I mentioned, the webinar is brought to you in collaboration with QIAGEN, but QIAGEN didn't have any role in selecting the speakers or selecting the topics or revising the material. So the material is all provided by the speakers and agreed with the society. Today, we do have two excellent speakers. The first one will be Dr. Morten Ruhwald, that leads the TB program at FIND in Geneva. Prior to joining FIND, Morten was chief and medical officer at the Statman Serum Institute in Copenhagen, Denmark, where he oversaw the clinical development of TB and chlamydia vaccines and specific skin tests for TB infection. At FIND, Morten is responsible for a large portfolio of R&D projects and trials spanning simple point-of-care TB detection tests over molecular assays and digital diagnostics to artificial intelligence-based tools. A key aim of the program is to develop and trial new non-sputum-based tests and sampling strategies to prepare for the post-pandemic recovery of TB programs in low to middle income countries. The second speaker, they will actually alternate. So Morten will set up the scene, then Alberto will take over and introduce incipient tuberculosis, and then Morten will come back with the spectrum of disease and biomarkers for cure. But anyway, Alberto is a full professor of infectious diseases at the University of Brescia in Italy. He is the director of the WHO Collaborating Center for the TB Elimination Strategy since 2010. In his career, Alberto worked for the WHO in Tanzania as malaria officer and at the WHO headquarters as a medical officer in the TB department. He played an active role in the preparation of all WHO guidelines on TB infection from 2015 to 2020. His activities include clinical work, lecturing to undergraduate and postgraduate students of clinical research. He has co-authored more than 270 publications in international journals. And most important of all, they are both fantastic speakers and very good friends and extremely pleasant people. So let's start with Morten and set up. So Morten, please go ahead and give us the brief introduction on the relevance of this topic in the TB field. Morten, over to you.
Thanks, Daniela. Can you all hear me?
We can hear you, but we don't see the first slide.
Oh, right.
So you need to move. Okay, and you
Great.
go. Okay, I will set up in mute.
Great. So I will start this double presentation by talking about the spectrum of disease and biomarkers for cure specifically. But the two presentations together will talk about biomarkers for incipient TB and disease progression and cure today, tomorrow, and in the future. So TB is a spectrum that if you are exposed, you can either have an elimination without the acquired immune response, so you will not have a positive IGRA, for instance. But if you have an acquired immunity as part of this, you will become quantiferin positive or IGRA positive, or skin test positive. However, in some cases, you might have eliminated the infection. The vast majority will probably have a quiescent or very controlled infection and will never progress to TB. Then we get into the more tricky part, and this is the incipient TB group. So these are individuals who are on the path towards developing active TB. At some point, they start to, you can do a sputum sample from them, and you can then get tuberculosis culture positivity, and some of these might actually aerosolize TB, but they're not experiencing symptoms yet. So we call these subclinical TB. And then in the active TB spectrum, you can have minimal disease with very few bacteria, all the way up to very advanced disease with extensive lung damage. And then if you start treatment, then you will probably progress through the same kind of stages again. But we know that the majority of patients, perhaps 80%, are perfectly fine and will never have TB again if they complete 4 months of treatment. But we need to treat the rest of them to prevent, for the full 6 months, to prevent TB happening again. So if we look at individuals like George Ruhwald, he had active TB and then he got incomplete treatment. He probably went back to subclinical or incipient TB, but it never eliminated. And then he later, about a decade later, died of TB. Desmond Tutu was also had active TB at a time in his career when he was young, and he self-cured and until recently was very alive and kicking without any symptoms. But the majority of people who have been exposed to TB, they will be around without ever actually knowing that they have been exposed. They will control the infection and they will die of something else when that time comes. So we're looking at a dynamic spectrum of decreased likelihood as well, where the majority will be around here and very few will actually develop advanced TB. These guys, they do not have infection. They would probably not need treatment. These people would need preventive treatment. These would need something else than active TB treatment. We don't really know at the moment. At the moment, we are only offering preventive treatment or active TB treatment. And we are quite sure that there is this gray zone in between where you probably just need a couple of months of treatment and then you're perfectly fine. But when you have advanced disease, you need multi-drug treatment. So we're going to talk today about some needs. And the first need we have is biomarkers to identify at-risk individuals, the incipient TB tests. Then we will talk about, or we will not talk about tests to diagnose subclinical TB. We don't really have any good idea about how to triangulate this space. yet. We'll also not talk about the needs for active TB case detection, but here I think we need more non-sputum-based tests that can be used at primary healthcare. We need better drug susceptibility tests. We also need tests to personalize medicine in TB, to say, okay, you have a specific immune response, you only need a shorter course of treatment, for instance. Those kind of tests we do not have yet. But what we will talk about is treatment monitoring tools, and that is what I will cover after Alberto has introduced the biomarkers for at-risk individuals. So I'll stop here and give the floor to Alberto.
Thank you very much, Morten. I'm trying to share my screen. Okay. And thank you very much to Daniela and to Morten for having set the screen, having set the scene. My first slide, I work at the University of Brescia in Italy, where it is hosted the WHO Collaborating Center for the TB Elimination Strategy. And as Morten has anticipated, I will go on with the introduction of incipient tuberculosis. Incipient tuberculosis is a concept which is not very ancient. We are talking about it only in the last 3 to 5 years. And again, as mentioned by Morten, it is incipient tuberculosis is an intermediate phase between the bulk of the population with persistent infection and the small number of people with tuberculosis and active disease. Even the difference between incipient TB and subclinical TB is an issue for discussion today. Let's say, incipient TB is identified and is defined by the presence in the blood of specific messengers RNA, which are called transcriptomics. And these transcriptomes are a combination of gene expression that identify the rupture of the latency of M tuberculosis. At that point, M tuberculosis starts its replication. At the beginning, the number of mycobacteria is not that high to be perceived by the individuals. There are no signs, no symptoms, and in the initial phase, probably it's not even possible to identify M tuberculosis with microbiological investigations. So what would be the role of a test for incipient TB? It would have a very specific place in as a rule-in test for the treatment of infection. Compared to the test that we have today for identifying people who need treatment for infection, TST and IGRA, it should have a much higher positive predictive value. The positive predictive value for TST and IGRA today is about 5% or something like that. This test for incipient TB should have a higher positive predictive value. And a positive test would be very significant in terms of an indication for treatment. Conversely, a negative test would not say much because it's very possible that a person has indeed an infection which did not yet start progressing towards disease. The typical situation where a test for incipient TB would be extremely useful is, for example, in taking care for household contacts of contagious TB. So what is the theory for a test of incipient TB? This was initially discussed in a meeting held in in Geneva in 2017. As you see from the title of that consultation, we are talking about tests for progression. Now we can call them a test for incipient tuberculosis. And this is a depiction of what such a test would be able to do. We are not in this part of the population where people may have persistent infection or cleared infection. This population has nothing to do with incipient TB, but the tests have something to do with the population that from the persistent infection pool starts replicating. And probably the majority of them will go on to active TB through the phase of incipient TB. Possibly some other will halt progression. So despite having markers of incipient TB, will not progress to active TB. But of course, the probability of progression is much higher when you are in this arm compared when you are in this arm. In that consultation in Geneva in 2017, one important concept was established, and that's the minimum targets for sensitivity and specificity for an incipient TB test. And these were set at 75% each with an horizon of 2 years. Sorry. This horizon of 2 years is very critical. An incipient TB test is able to predict a next disease, a coming disease, but whether this is a near horizon or a long horizon, that's a very important issue and question. The 2 years period, which appears here, come from initial data which were coming from example from a trial in South Africa. We are going to look at it later on by Zach. And we're also coming from a publication by Sandra Kick on the theory of progression, the way of progressing from infection to disease. So if this is the theory, what is the evidence which comes from clinical trials? As I was saying before, the initial and really game changer paper was published by Zach and co-workers in South Africa. They in a retrospective course from South Africa in Gambia, they tried a 16-gene signature, and they tried to define whether this signature could predict tuberculosis in the 12 months, in the following 12 months. And that test was very predictive because the sensitivity of the signature was 66% and the specificity was 80%. Initial problems were already identified. For example, the cohort in the Gambia performed worse than the cohort in South Africa, showing that geographical diversity may have an impact on this kind of test. From that moment on, several publications followed on different signatures. And here is a publication from Pam Nicholson on a 6-gene transcriptomic signature, which was directly derived from the one used by Zach. And as you can see from the two pictures, here is basically the predictive value of 12 months, which was 70%, and at 24 months, which was lower, 67%. Not much, but lower. So this points out already to one of the most important problems with this type of signatures. They are very much time dependent. And then the second aspect you can see in these 7 cohorts, there were people from South Africa, the Gambia, and Ethiopia. And again, the performance of the test was slightly different in the different settings, showing that the geographical diversity of mycobacterial strain may be a problem for this type of test. Going on with the publication, an important publication from Gupta and co-workers basically made a trial on 17 candidate signature, 17 messengers, which were tested on a pooled data sets from more than 1,000 people. Of these more than 1,000 people, there were 127 with incipient tuberculosis, so they had a positive sample and a control sample. Of the 17 signatures, 8 were, let's say, promoted because they got close to the performance which is required by the WHO for a test to be endorsed. But a common feature of these 8 signatures was that they are very much time dependent. And as you can see here in this picture, this is what happened if you take the results at 24 months, at 12 months, at 6 months, and at 3 months. So it's clear that the positive predictive value, which has this 3 line, 15%, 10%, and 5%, it reaches acceptable level only when the horizon that you take is very short. And here the authors concluded between 6 and 9 months horizon, not the 2 years initially considered. And then here there were the results of an important trial which started already in 2017, the Cortis trial. They built directly from the initial findings of Zach. They produced a derivative RISC-11 signature, and they tried it in a prospective trial rather than retrospectively. And what you can see here that if this is the minimal target product profile performance, and this is the optimal target profile performance, this signature worked well only with an horizon of 6 months, and did not work well enough after that time. And here you can see that in the initial 6 months, in the initial 6 months, the sensitivity of the test was very high, 90%. It dropped in the first 12 months down to 75%, which is still borderline, but then was unacceptably low after 15 months. In that same trial, we have the only available evidence on how to treat incipient tuberculosis. In that trial, they took the risk-positive people, so a surrogate of people with incipient TB. They divided in 2 cohorts. One was treated with a standard regimen for the treatment of infection, 3HP, and the control group was not treated. And then they measure the incidence of tuberculosis in the 2 cohorts. And as you can see here, the incidence was very, very similar in the 2 cohorts, with a treatment efficacy which was definitely non-significant. So the interpretation of the Cortis trial was that the blood markers are good, in revealing the spectrum of NTB infection from infection to the disease, but the horizon that should be considered for this interpretation, for this good interpretation, is only 6 to 9 months. And the other important conclusion or let's say findings of the study were that very unexpectedly a regimen, a very good regimen for the treatment of infection did not work for the treatment of incipient TB. And they just speculate that here you might have a problem of reinfection being in South Africa, or most probably that that regimen is not sterilizing because it's not strong enough for an already advanced form of the disease. And they also speculated that in a setting like South Africa, the high prevalence of respiratory viral and viral diseases of the respiratory tract may also be an interference with the results that you get with your test. So to conclude, where are we and what could be the contribution for treatment of incipient TB in the frame of the NTB strategy targets? Here we need to consider that there are out there 1.7 billion people with the infection. And if we want to really get the targets of the NTB strategy, we need to eliminate them. We are going at a very slow and very cautious pace. If you consider that at the UN high-level meeting on tuberculosis in 2018, the member state got or decided a target for 2022 of 30 million people treated for latent infection. 30 million people is 1.8% of the infected pool. So you can imagine how much is left to do for the future, and how difficult is it to really get to the NTB strategy with the tools we have in our hand today. So to conclude, the management of incipient TB is challenging. We have good predictive tests, but they only work in the very near future. They are probably useful and suitable for specific population, typically household contacts. Their impact on the burden of the population with infection probably will not be very large. The signatures that we have today might not be the final answer because of geographical diversity of the mycobacterial population, and the last point is that definitely the incipient TB test should play a role in the TB elimination strategy, but they're not the final answer, and the final answer would probably be a test for persistent infections, which unfortunately is not on the horizon. I thank you very much for the attention, and I send back the ball to Morten.
Thank you very much, Alberto. I invite everyone to start typing the question in the chat, and Morten, over to you. Thank you.
Thank you. Can you hear me and can you see my slides?
We can see your slide and we can hear you.
Perfect. Great. So thanks a lot, Alberto. So I will pick up again on the spectrum of disease. We have now heard about the incipient category, and I'll try to sort of put it a bit in context of the diagnostics tools we have and how we are trying to use these diagnostic tools also for treatment monitoring. So for advanced TB, it's clear we can use smear microscopy, we can use PCR-based tools, and culture probably is more sensitive, so we start to also be able to diagnose the subclinical TB. Chest X-rays, very sensitive as well, and the IGRAs we've talked about. So for treatment monitoring, some of these tools are being used as well. Smear microscopy, you can look at when are they smear converting, but the tool really never doesn't give you a good grip over whether these bacteria are alive or dead. It's the same with the PCR-based tools. They will remain positive for a long time, often or sometimes many years. The culture systems are great when you ignore the fact that it takes several weeks to give you a result. So that's not really a dynamic tool. And the chest X-rays, it's a bit, they might still remain positive for a long time, and the IGRA is the same. So I'll try to talk about what is in the pipeline of new tools. And there's a class of technologies around host-based tools, developed either in animal models or studying human TB. And then there's a class of technologies around the bacteria. So I will talk about transcriptomic signatures, not used as an incipient test, but more as a treatment monitoring tool. And I will talk about the use of imaging here, but there are also other tools like cytokine profiling or host adaptive immune responses, but for the sake of time, I would not have time to cover this. For the MTB burden assays, I'll talk about rapid molecular tools to determine the bacterial burden, and then also some interesting new tools that not just determines how many bugs there are, but also how alive, how fit they are. So I'll start by these host characteristic assays. Alberto has talked about transcriptomic profiling assays, and I'll give it a bit more of a product spin. So there is, from Cepheid, they are developing the Sweeney 3 signature. So it's a 3-gene signature into a cartridge. It's a quick cartridge. It takes about 30 minutes to diagnose, to run. It has an ability to diagnose TB, as was beautifully shown by Jane Sutherland, and also in a paper that we did together with Cepheid from Fineside. But when it comes to treatment monitoring, so the normal non-TB patients will have a score of around 2.3. So here, this is the start of the treatment. You can see there's sort of a normalization of the score. In this study, over the first month, there's really a rapid change. However, we do not really know how this tool works if you are given incomplete treatment or if you have relapse. So this is basically just correlating in people who have a good treatment response. Another approach to a transcriptomic assay for treatment monitoring is the so-called therapy end model score. It's currently a research tool developed by Christoph Lange and Jan Heikendorf and many others from Borstel and others. So they measure 22 genes that they have selected with the intention to drive individualized therapy duration for MDR-TB. So they developed this score by looking at a score. So a score of about 0.5, they say that is the limit for when you will have relapse-free cure. And then they compared drug-sensitive TB as an effective TB treatment, and then MDR-TB treatment as an ineffective treatment. And they did observe two different kinetics of this. And they claim that those above 0.5 here, you do not need to treat them anymore. So you can see here that a lot of these patients who were followed up for a long time, they could perhaps have terminated the treatment earlier. They validated this signature in a Romanian cohort, and you can see that it is suggested that here that the majority of these can actually be stop the treatment relatively early, some perhaps even after 6 months treatment. Of course, we need to understand this signature in more studies. Alberto talked about the 16 signature by Nicholson and colleagues. There have been some treatment monitoring measurements with this tool, and I can say that it is under commercial development with Quantum DX. The project got a bit derailed due to COVID. However, they are still pursuing this. But you can see here already after 1 week in South Africa, South America, and also in people living with HIV, from a mixed cohort, there is quite a rapid decline, particularly here in the South African cohort, where they measured after 1 week. So it does seem to correlate, and they claim it has an ability to predict cure based on the magnitude of response already at baseline. And that could be a tool to say, okay, you are in a specific category, you need longer treatment versus others who might have a lower baseline. And finally, there is the film array from Biomarkers. It's a transcriptomic assay that is using 30 markers. It might not be that relevant for lower and middle income countries because this is an expensive platform to run it on. But as a diagnostic for TB, a non-sputum based diagnostic, it seems to have very good performance. And they are now pursuing or looking at the treatment monitoring ability in this study. And it was built on the original Barry Bloom 396 signature that basically started the whole story about the use of transcriptomics. So the next class of technologies I've chosen to present here today on sort of the host side is to use chest X-rays. And it's well known that chest X-rays, there is some improvement over time. But when you ask a radiologist, you're not going to get a very detailed response in sort of how much has it improved. So there is these artificial intelligence softwares called CAD that are being used for screening or triage of TB using X-ray in many parts of the world, and it was recently reviewed by WHO as well. And some of the manufacturers now have modules that allows you to take images over time and compare them. So it gives a score from 0 to 100, and you could imagine that there would be a slight drop or a large drop in this score, something that an AI would be able to give a much more objective view on than a human who would also look at the clinical history, etc. And these systems are sort of, they adjust for rotation and other things before they put the algorithm on top of this. So we need to understand how these work. And they are commonplace in oncology, for instance, following lung cancer patients over time. So moving now to the other class of tools, and that's on new technologies looking at the bacteria. And the first one, and perhaps the most quirky one, is the so-called Culturefree TB test assay from Torns in Japan. And Torns are well known for the MPT64 TB verification assays using that are in use in many parts of the world. So they kind of used that technology and built a new tool on. So you do a sputum sample here, and you do a bit of sample prep here, and then you put it in a specific buffer. Then you heat treat it for 1 hour at 46 degrees, and then you measure the response the bacteria have to this heat shock. And that interestingly leads to a secretion of this MPT64 if these bacteria are in a good state of fitness. So they need to be alive, and they need to also have a well-working biochemistry or protein synthesis. And then they measure the release of this MPT64 with the semi-automatic ELISA they've developed a cartridge for. So it's kind of an immunoassay that utilizes this really interesting physiological response from the bacteria. And when you look at how this compares to smear grade, it looks very nice. How it compares to midget time to culture positivity, it looks great as well. And they actually have done a study where you can see this is a bit of a busy slide here, but you have the midget time to positivity here, and then they have 16 patients who are midget negative at week 4, and then they have 14 patients who remain midget positive or culture positive at week 4. So you can see here, these guys, they drop at day 28, they are negative in the culture, and then the other ones here, they remain positive. With this culture-free TB test, they are all, there's only 2 out of 15 that remain positive here, where 12 out of 16 remain positive over here. And 2 individuals had persistently very high results, and they were also the ones with the most, the clinically worst outcome. One had multiple cavities and passed away, and the other one had pulmonary cancer and was severely immunosuppressed and had a really poor ability to control the infection. So this is a tool that gives you a result within 2.5 to 3 hours with a relatively simple workflow. The other one, which has found a lot of use in drug development trials, is the so-called MBLA assay that is now under commercial development with Lifearc in the UK. So here you do a sputum collection, you extract the ribosomal RNA, you do a simple qPCR, and then you measure a certain ratio of some of these RNAs. And you can see that for the bacterial load here, measured at CFU in culture, that drop you will see over treatment corresponds very well with a, the drop you will see in the MBLA assay corresponds well in an increase in the time to culture positivity in liquid culture. And again, this is a very fast assay that could substitute the culture-based systems. Another very researchy project still is from the University of Colorado. And here they're again looking at ribosomal RNA. And here they're looking at splice, some out splices in a ratio against the 16S and the 23S RNA as a measure of the amount of RNA that's being produced in the MTBs that are in the sputum sample. So again, this is a measure of the physiological properties and not just counting the bacteria. And you can see here the RS synthesis ratio corresponds well with the efficiency of the regimen in this mouse model. And you're seeing the same with the colony forming units. But this is again a very fast way to determine or to measure. The last one I'll talk about is the Lsi Medicine company, also in Japan, who are measuring LAM in sputum. So this assay, you do a sputum, and then you do a sediment, you do boiling to inactivate, and then you, from this extract, you basically put it in a high sensitivity automated ELISA on the PathFast platform that looks a bit like the VIDAS platform from bioMérieux. And that gives you then a result within 3 hours. Correlates very well with the CFU, and also correlates very well with the midget time to detection. Otsuka have developed this ELISA, which they have used for the drug program, and it is being pushed as a sort of a tool for really early. You can do these trials where you do an interim analysis, and then you based on the treatment response, you can then eliminate some arms and continue with fewer treatment arms in real time, instead of stopping the trial and starting with a new group of participants. So I think tools like this will have a big impact for drug development. And I'll just finish off by talking about 2 drug development consortia. There's the Unite for TB, which is a very large European Union, EU-sponsored project that will run over, I think, 7 years and have a budget well above 100 million euros. And then there is another one of similar size by the Gates MRI. And these two consortia will push in a lot of new regimens into the pipeline over the next 5 to 7 years. But a part of this, there'll be a lot of development of these tools to monitor treatment effects. So I'm really hoping that one of the positive spins from this will be new tools to do treatment monitoring. So I'll just stop here by saying there is a growing pipeline of host and bacterial markers. They are fast, they are more simple than what we have now, and hopefully also more accurate. But there is no real good standardized process for evaluation. We don't know which optimal time points to go for. And there's no clear pathway for WHO policy or national policy on this. And I'd just like to highlight that major gaps remain. If you look at the new WHO report, we had 4.2 million who were not even diagnosed. So you need to diagnose all of these people before we start monitoring treatment. Of those that were diagnosed, 1 in 3 are only bacteriologically confirmed. Only 1 in 5 are diagnosed with a molecular diagnostic tool like GeneXpert, and only 1 in 3 who have drug-resistant TB are put on relevant treatment. So it's critical, really focus also on the diagnosis and use the tools we have now. I'll stop here.
Thanks a lot, Morten. Thank you, Alberto. And I think was extremely interesting to hear both of your talk. And while we are waiting for the question to come, I do have a question for you. I mean, you mentioned the United for TB and the PAN-TB consortia. Those are consortia that will try to push ahead the new regimens, not only new drugs, but also new association, trying to be shorter, less toxic, move to complete oral regimens. And of course, they are in desperate needs of early biomarkers to be able to predict which regimen will be the regimen to be pushed towards the phase, towards the final trial. And they will start with several regimens, but only we do have enough resources. I mean, there are available not sufficient resources and not even probably sufficient clinical trial centers or patients to really move ahead all those regimens. So which do you see as the most promising biomarkers for the trials, and which do you see the most promising biomarker to be used in the clinical care? Because not necessarily will be the same, considering cost and considering feasibilities. And I think, can you elaborate a little bit more on that?
Yeah, I think it's very important to understand the number of bacteria and how alive they are. And currently the tools we have are not really good enough for these. So things that somehow measure the physiology of these tools. And that could be one of these RNA-based tools or this MPT64 secretion assay. They are currently a little bit too complicated to implement for clinical management. There are a lot of steps in some of these assays, but if we had something like a GeneXpert cartridge on one of these tools, it would be quite simple to work with. So that would be for patient management. For the drug trials, money is not a problem. You are spending several $1,000s to run one of these trials. So here we can actually work with very expensive biomarkers if they are good enough. And one of the, I'm part of the work package on biomarkers here, and one of the aims that we have signed up to deliver over the next couple of years is biomarkers that you can take perhaps 1 or 2 samples really early on in a treatment and then predict relapse-free cure 2 years later on. And of course, that's a high bar to set, right? And we are aspirational, and we hope to be able to develop this. And if we do that, imagine a world where we had a biomarker you could measure twice over the first 2 months of treatment with a new regimen, and you could then say, this regimen is fantastic, this regimen is not so good, continue with that one. And if that was then adapted by the EMAs and the FDAs of the world, we could really test a lot of drugs very, very quickly.
We need to be aspirational anyway, otherwise we don't move a bit from expert and or the mole bio, and we need to have something more. But exactly. Going back to the MTB64, would that be affected by the number of bacteria that you have in your sputum sample, or from the different strains? Not all the strains are really good producers.
Yeah, I don't know. There's no data on this yet. That's a good question. Yeah.
Okay. Yeah. And I do have a question for Alberto. Alberto.
Yeah, I'm there.
Okay. And I was thinking, how do you see tests for incipient TB entering and in the next few years, considering that the one that has been tested, the signature that has been tested, is really a signature that can predict tuberculosis within 6 to 9 months maximum, and that would require several testing and is quite expensive. Do you think that there is a future for this, or how can those be? I mean, do you see those as a two-step for, you start with an IGRA screening and then just the IGRA positive people in low burden settings will be tested for a couple of years, but those should only be a recent contact, because otherwise it wouldn't make any sense to me. But I don't know. Can you elaborate a little more on that?
That's exactly how you have said. In my conclusive slide, I mentioned that a test for incipient TB will not be an answer for a final answer for the TB elimination strategy, and it might be part of our armamentarium in the future, but cannot be the only tool to manage infection. The clear indication I can see for this type of a test in the management of contacts. And as of today, for example, if you think about that, people who are put on treatment for infection just belong to 2 categories: people living with HIV or household contacts. So at least for the second population, a test on incipient TB would make a lot of sense. Here, the timing is right, because the majority of people will need to be tested only once or might be twice after the contact. And the test would be a big advantage compared to the IGRAs we have now, because its predictive value is definitely much bigger. We could definitely use, for example, the same regimens we have today, even without having big new findings in less toxic and shorter regimens. The issue of how best to treat incipient TB is still completely open, and will need to be resolved before we start using in clinical practice these tests.
Would you consider a scenario like this? You have someone that is a contact in low burden settings where the cost of the incipient signature is not a major problem. I mean, now transcriptomics is part of the medical armamentarium. And would you consider this scenario? So you have a contact that convert as positive with one of the many interferon gamma assays and is older than 35. So you need to decide if it's worth to treat with isoniazid, and if the person for any reason has some kind of sign that the preventive therapy could be toxic for him, would you consider testing a couple of times with a signature to decide if this person should be treated or not? And then we will discuss the treatment, because as you mentioned, if it's positive, then you need to decide if you would go for 4 months with 4 drugs, or 4 months 3 drugs, 4 months 2 drugs, whatever. I don't know.
No,
would you consider that as a possible application?
No, the vision I have is that for the management of household contacts, incipient TB test should replace the other tests for infection. So I don't see them in sequence. I see them
even in children. Would you use this for children as well?
Yes.
You would. Okay.
Yes.
So that is a replacement test for IGRAS. If you are a true, a very well documented contact of a smear positive or smear negative case.
Yes, the problem is that contacts are a very important target for population for prevention, but they are not the only one. And in the other population, it would be more difficult to file an application for an incipient TB test.
Well, what about immunosuppressed that go for a therapy? So when out of the blue you find out that someone is IGRA positive and you need to offer the preventive therapy. I mean, if we had a preventive therapy that would last like 3 days, and non-toxic at all, we wouldn't be discussing this probably.
But I also think that, for example, for people with an acute immunosuppression, immunosuppressive disease, then if they are positive in a test for infection, I think that in that category, I would treat all of them for infection. So there, where the risk, the population is small, relatively small, the risk is very high. And there, I think that the currently available test for infection still work. The problem is if you try to expand with the population, where I mean the risk of progression is much lower, then you can really you cannot rely on a simple test for infection because the probability of progression is too low.
Okay. Thank you, Alberto. Thank you, Morten. We are now at the hours. I assume that in analogy with what happened in other webinar, we will get the question after. We will be able to forward those to you. And I would like really to thank you a lot for your availability. I know that you are very busy. This is a difficult time for all. I would like to thank the people that were connected and to remind all of you that we will have the meeting probably in Bologna at the end of June. And so after 2 years, we will be able, hopefully, to meet again in person. Thank you very much to all and have a very good rest of the afternoon. Bye-bye.
Thank you, Daniela. Thank you, Morten.
Thank you.